So we're going to talk a little bit about the different medications that we use in Parkinson's disease today. There will be a question and answer panel right at the end, so if anyone has any questions, we'll probably be able to answer most of them. There's only 30 minutes and I see more than 30 faces here, so we'll try to do our best. But just to get started, we'll go over a little teeny overview of what Parkinson's disease is versus the other things that can cause Parkinsonism. We'll go just over basic, what are some of the motor and non-motor symptoms of Parkinson's disease that one can maybe expect to have in Parkinson's disease. And then we'll talk about the different medications that we use in Parkinson's disease and when I use them. There is a PowerPoint associated with this, but I kind of like talking better than just using slides, because looking at slides with a bunch of text is boring. It's kind of hard to digest sometimes, and so we'll kind of go through all the different medications we use. So, when we think about Parkinson's disease, that's only one of the things that can cause Parkinsonism. And I'm sure that a lot of you, when you've interacted with your neurologist, they've said, you know, we think this is Parkinson's disease, or maybe this is something that mimics Parkinson's, or maybe there are a couple different things that are causing your Parkinsonism. So like I said, Parkinsonism is a symptom, and Parkinson's disease is a specific diagnosis. As we go through this, I think I have it. Oh yeah, it's up there. Okay, as we go through this little web, there are causes of typical Parkinson's, which are the Parkinson's disease, and eventually Lewy bodies, which is different than Parkinson's disease. Those typically present with asymmetric, meaning more on one side than the other, motor symptoms, as well as some non-motor symptoms. Sometimes people get problems speaking or swallowing, lightheadedness or sexual dysfunction or problems sleeping. So there can be a lot of symptoms associated with these conditions. There are a lot of causes of atypical Parkinsonism. So there are conditions such as the Parkinson's plus conditions, like PSP, MSA, and CBD. Maybe some of you have heard some of those names. There's also drug-induced Parkinsonism, so certain medications can cause something that mimics Parkinson's disease. There's vascular Parkinsonism, meaning that diabetes and high blood pressure and high cholesterol can actually cause something in the brain that at times mimics Parkinson's disease. And then there are a lot of other atypical causes that we see a lot less frequently. One of the things that makes typical Parkinson's disease typical is that you respond to the medications that we use in Parkinson's disease. So just a little bit about Parkinson's disease. The normal age of onset is 45 to 70 years old. In certain situations, people can get it in their teens. Sometimes people get it much later, but it just really depends on the different risk factors that someone has for Parkinson's disease. It's about the incidence, meaning the number of new cases we see is about 13.4 per 100,000 in the population, so it's pretty common. Men get it a little bit more frequently than women. We think there's a little bit more higher preponderance to get it in rural areas, possibly due to well water or possible pesticide exposure. We're not exactly sure. And then we think in some cases, maybe there's a genetic predisposition to people getting Parkinson's disease. There are a lot of motor symptoms in Parkinson's disease. When I used to teach medical students to help them remember, I would say, just remember the word TRAP, T-R-A-P. So the T stands for tremor. Typically it's asymmetric and resting, meaning more on one side than the other. And some people call it a pill rolling tremor because it almost looks like you're rolling pills in your hand. So T-R, the R is for rigidity. So people get muscle stiffness, and that can present as limb muscle stiffness. People can get that dystonia that we just heard about in their neck or in their feet. And it can present in all parts of the body. A, so it's a medical word, it's akinesia, which means lack of movement or slowness of movement. And that's something that we see interfering with people's ability to have good facial expression, moving their limbs quickly, can interfere with their walking, can cause low voice volume, so it can cause a lot of different things. And then the P is postural instability, so people can have problems with balance. Along with the problems with the motor symptoms, we think about what's causing that. And typically that's a lack of dopamine. People with Parkinson's disease have an abnormal form of a protein that accumulates in dopamine-producing cells and actually causes these little groups of these proteins in cells that are toxic. When those little groups of proteins accumulate, we call those Lewy bodies. So people with Parkinson's actually have Lewy bodies. I don't want to say that everyone with Parkinson's disease has Lewy body dementia. That's a different thing. But people with Parkinson's disease have these little accumulations of protein that are toxic to the cells. Those dopamine-producing cells actually die, and when you've lost about 60% to 70% of your dopamine-producing cells, you present with the symptoms of Parkinson's. And that's the whole reason that we use different dopamine medications to treat Parkinson's diseases, because we're trying to make up for what you've lost. This is a big long list, but that's just to say Parkinson's disease isn't all about tremor and slowed movement. There are a lot of different non-motor symptoms that can present in Parkinson's disease as well. And it's a long list. I'm not going to read through it, but that's why the appointments are typically a little bit longer. We ask a lot more questions because treating Parkinson's disease is more than just treating tremor or muscle stiffness. We've got to make sure we're taking care of the whole you. So, how do we make the diagnosis of Parkinson's disease? We take a detailed history and physical. We want to make sure that you match one of those diagnoses on that tree that I just presented to you, and we try to make a decision whether or not your case is typical or atypical, because it can change both the way we think things are going to happen, how we expect you to respond to the medications, and then also changes the medications that we use. We also look for medication response. As I said, typical Parkinson's disease typically responds to the medications. We also want to rule out other cases. Sometimes we send labs or get imaging if we're scratching our head and trying to figure out exactly what's causing your symptoms. But it's just a lot of different things that we take into account each time we see people, and that's how we diagnose. So whenever I talk to people about treatment of Parkinson's disease, I always think about the 3 branches of Parkinson's disease treatment. I always think about non-medication things and non-surgical things, which I call rehabilitation. We think about medications that we can use for Parkinson's disease, and then interventions, like surgery. So we'll go through each of these. Rehabilitation is super duper important, and there are a bunch of different ways to do rehabilitation. Whenever you come to see me, we ask a lot about speech and swallowing and balance and gait and movement and cramping and a lot of different things, because these are all things that can be treated by rehabilitation. So a lot of the times we recommend physical therapy for gait and balance. We recommend speech-language pathology evaluation, who are the speech and swallowing specialists, for people who have problems projecting their voice and also problems swallowing. We recommend occupational therapy sometimes for people who have cramping in their limbs or who have tremor. And then we also recommend exercise, which I'm sure all of you have heard about. Because exercise is one of the only things that we found that can potentially modify the progression of Parkinson's disease. And so staying active is really, really important in Parkinson's disease. And depending on what symptoms you're having, sometimes we look to the speech-language pathologist or the physical therapist or occupational therapist to help us figure out what exactly is the right exercise regimen for you, what's safe, and what can give you the most benefit. So then we think about medications, and I'm sure that most of you are on medications. We take a lot into account when we think about what medications we're going to use for people, and if we're going to use medications. A lot of the times people think that all doctors want people to be on medications, but a lot of this is subjective. I've had people have a little tremor like this and say it's really bothersome to them, and I've had people have massive tremors or muscle cramping, and they're not very bothered by it. So a lot of it is based on what our interaction is with you, and what is subjectively bothering you about your condition, and that's a huge part about what we choose to do with the medications. We also make medication changes based on what your motor and non-motor symptoms are, like we talked about before, what your age is, because that actually has a huge impact on what medications we choose. We look at your other medical conditions, if you have high blood pressure, depression, or other things that are being treated that could interact with the medications that we use. And then, like I said, patient preference is huge, because I'm not going to make a decision if it's not in line with what you guys are thinking. Okay, so we're going to go through the different classes of medication, kind of from the beginning to the end. And we're going to talk about the medications that we use to treat the motor symptoms of Parkinson's disease. So, and we can answer questions about these later. So the first kind of group of medications that we use are the MAOB inhibitors. Those are selegiline and rasagiline, which is also known as Azilite. So the MAOB inhibitors actually decrease the rate that your body breaks down the dopamine that you're still producing. in the brain. It's a medication that typically we use early on in the course of Parkinson's disease, as it can give you a mild benefit with respect to controlling your motor symptoms. Sometimes we use it later in the course if people are having fluctuations, kind of like you're feeling good part of the day, and then you're feeling bad, because in some people that can help smooth that out. And then also in a very small subset of people it can help with freezing of gait. So sometimes we try that medication for that condition. This medication can have the potential to interact with antidepressants or other medications, and so we always look to see what medications you're taking to make sure that this isn't something that's going to be interacting with the other medications that you're on. The next group is the dopamine agonists. These are medications that go and actually turn that dopamine receptor on. It's not dopamine itself like that Cinnamon or carbidopa-levodopa. This is a medication like Nupro, which is rotigotine. That's a patch that not many people use. But the other ones are the Requip, which is ropinirole, and Mirapex, which is pramipexole. These are great medications, and they work very well for a lot of people under the age of 65. These medications work for different conditions like tremor. They can help with muscle stiffness. They can help with fluctuations up and down during the day. They can actually be very helpful with restlessness. But after the age of 65, we do have to be careful with these medications. These are the ones that you've heard about potentially causing impulsive or compulsive behavior from time to time. So we always screen at our appointments for gambling or addiction or a history of impulsive behavior. These medications can actually cause hallucinations as people get a little older. They can cause insomnia. They can cause leg swelling, and so these are medications that we do use with caution and are better used in people who are under the age of 65. That being said, I have a lot of patients who are much older than 65 who are doing very well on these medications, so I just monitor them closely to make sure that they are continuing to tolerate their medications at each visit. It's kind of a funky clicker. I guess I can put it on the neck and then I won't lose it. So the next medication is one that most of you have heard of. This carbidopa-levodopa. It is the gold standard medication in Parkinson's disease. So the other name for it is sin-amet. So that comes from the Latin sin, without, amet, emesis, or vomiting. Because the carbidopa prevents the levodopa from being broken down outside the brain and causing side effects. If everyone took dopamine, a lot of people would have nausea, lightheadedness, fatigue, but because that carbidopa prevents it from being broken down outside the brain, a lot of people get away without having many side effects of that medication. Also, by blocking its breakdown outside of the brain, it actually increases the amount of that medication that you have in your blood and increases the amount of that medication that can get into your brain and give you the benefit that it's supposed to. The levodopa, or L-dopa, just a little bit about the medication, is a different structure of dopamine that can actually cross into the brain. Because a lot of the times if you just took pure dopamine, that actually isn't very good at crossing from the blood into the brain. The L-dopa form is. Once it crosses into the brain breaks it down into dopamine. And then the cells can use it, and especially those cells that do tremor and smooth movement and speed of movement. So that's why it works. It's a very good medication. You know, if people are intolerant to other medications like those dopamine agonists or the selegiline or the Azilect, or if you're over the age of 65, sometimes we think about using this medication either first or in addition to these medications. This is also the medication that typically in some people causes dyskinesia, which are the extra movements that we see in Parkinson's disease. And that typically occurs because the dopamine receptor just gets a little dysregulated. It doesn't function completely correctly. And so people can get dyskinesia from this medication. Not everyone does. And those are the dance-like movements you see sometimes. Not everyone gets dyskinesia. And it's very hard to predict when someone's going to get it because everyone's different. Some people never get it. Some people get it with their first dose. But you know, I don't think it's a reason to not take the medication because we do have good ways of managing dyskinesia if it happens, and this is a very effective medication. Also, some of you, it's funny, I was putting together a little research thing, and some of these medications were in that research talk that I did a couple years ago. But Rytary is a different form of levodopa. I'd say it's like levodopa in a different package. It's a capsule that has immediate and extended release microbeads in it. And so some people who take carbidopa levodopa 6-7 times a day because they feel as though their symptoms are kind of going like this throughout the day could have benefit from Rytary, because Rytary can give you a little bit more predictable, sustained response. It's not a one-to-one conversion, and sometimes it's a little rocky getting over to Rytary. Some people do great on Rytary, some people do not so great on Rytary, but it's just about finding what medication is right for you. So this is a slide with a lot of text on it, but I just wanted to say a couple more words so that at least you've heard of all the different medications, main different medications that we use in Parkinson's disease. The one at the top is called entacapone, and some of you have heard that in combination with the carbidopa levodopa with the name Stalevo. That medication, so entacapone also decreases the rate at which the levodopa is broken down. And so it can potentially give you 30 minutes more of on time per dose. So sometimes we use that in addition to the levodopa. This medication can worsen dyskinesia. It can cause abdominal pain and also turns your pee bright orange, which some people say is exciting. But sometimes its use is limited by the fact that it can worsen dyskinesia. So if you're having fluctuations throughout the day, but none of those extra movements, which we call dyskinesia, sometimes this is a good option for you to potentially decrease the need to increase the frequency of your medications, but it can worsen dyskinesia or cause abdominal pain. There's a mantidine, or the extended release mantidine, which just came out, called GoCovery. We're not exactly sure why a mantidine works. It works on different receptors in the brain. It was initially developed as an anti-flu medication, and then later on we saw that it did have some effect in Parkinson's disease. Amantadine can actually decrease dyskinesia in some patients. We also use it for cramping sometimes in younger patients and for treatment of tremor. We do have to use amantadine carefully because as you age or if people start having cognitive issues, it can cause some problems with thinking. It can either cause fatigue or people to feel more stimulated. And so we just have to use that one with caution. This one can also cause a rash that's just cosmetic, and sometimes it causes swelling in the legs. So it's a pretty safe medication in a lot of people, but like I said, we just have to make sure that we're all up to date as to exactly what you're taking and what your symptoms are. What else do we have on here? A lot of you probably haven't heard of this one, but maybe some of you have if you're younger. There's another medication called Artane or trihexyphenidyl. It's kind of a mouthful. But we use that medication for cramping and tremor in younger people. And then there's another medication called Apokyn. This is a medication that we use as a rescue medication for people with very severe Parkinson's disease and unpredictable offs. Like the medication just all of a sudden will wear off and they'll have a very severe off period. It's a medication that they can take and immediately have an effect. We don't use that medication very often and only in certain cases. I know that you've tried Botox, and I think we heard about that earlier. Botox can be used for a lot of different indications in Parkinson's disease. Some people use it for drooling, because it actually can decrease salivary production. You can use it for muscle cramping in the neck or in the feet. So there are some different uses of Botox, and that's something that we do up here in Everett. In the right clinical context, it can really help with some neck pain in Parkinson's disease sometimes, or drooling. And so that's something that is available for people with Parkinson's disease and is actually pretty safe. And there's another medication that I just wanted to put in here too, because I know this is mostly about the motor symptoms, but one of the new medications that I get a lot of questions about is this Nuplazid, or pimavanserin, which is for the treatment of hallucinations in Parkinson's disease. The reason this medication is kind of new and interesting is because it doesn't work on dopamine like a lot of the typical antipsychotic medications that we used to use. It works on serotonin receptors, and so we think that some people can have improvement in their delusional behavior or hallucinations without worsening their movement disorder. because some of the antipsychotics that we use can potentially have an effect on tremor or slowness of movement, so this might be a safer option depending on the right clinical context. There are a lot of other medications that we use for the non-motor symptoms. Antidepressants or medications to boost blood pressure or medications for your bowel or bladder dysfunction. There are a lot of sleep disorders that can come with Parkinson's disease, and so that's why we spend a lot of time going through the different symptoms of Parkinson's disease at each appointment to make sure we can find the right set of medications for you. And also limit them, because we never want people to take too many medications. And then we'll just go through two more things. If medications fail to treat the symptoms of Parkinson's disease, or if you're having side effects from medications like dyskinesia, or if you're having dystonia or uncontrolled tremor, sometimes we think about other things that we can do to supplement your medications and hopefully give you more independence from your diagnosis. One of those things is deep brain stimulation. I know that some of you were at that VBS talk we gave over at Blue Water Distillery a couple weeks ago. Deep brain stimulation is a procedure where they put surgically implant electrodes deep into the brain, into one of two structures. They can do it on one side to give you symptom control on one side. They can actually do it two sides at the same time. The goal is to decrease the amount of medications you're taking, possibly improve the control of your motor symptoms, including tremor and dyskinesia and muscle cramping, while also limiting the medications like we said. A lot of people have DBS, and some people do really well with it. Some people have a favorable response, and very infrequently people don't respond to it. But we think that people who have had some levodopa responsiveness, meaning that the medications we use in Parkinson's disease have actually helped them with their symptoms, we think that those people are typically pretty good people to respond to DBS. The one thing is, we do a lot of testing in Parkinson's patients before we refer someone for deep brain stimulation to make sure that they're safe. Everyone with Parkinson's disease typically sees a speech-language pathologist, a neurologist, and or a physical therapist, as well as a neuropsychologist to test their thinking, because deep brain stimulation does have the risk of potentially causing problems with thinking, problems with speech, problems with swallowing, and problems with balance. And so a lot of the reason we do all this testing beforehand is just to make sure that we can have an open and fully informed discussion about what the potential benefits and risks of DBS are before we refer you to that procedure. And then the one other thing I wanted to just talk about is something called the Duopa pump. Has anyone heard about the Duopa pump? Yeah, so I see a lot of heads nodding. So this is actually a pretty good option for some people. So what a Duopa pump is, it's almost like a feeding tube for carbidopa levodopa. You get a little peg, almost like a peg tube or a little button on your stomach that has a tube that goes into it, and it goes into the first part of the small intestine. It's connected with a box on the outside, and throughout the day, it's a continuous infusion of a liquid form of levodopa. So who would be a good candidate for this? So if you're having big ups and downs throughout the day, you're having to take your medication very frequently, if you're having a lot of dyskinesia, we call it peak dose, kind of like you take your medications and then you start having a lot of extra movements when you reach the peak amount in your blood, or if you're having a lot of side effects from the medication. We also think it's beneficial in people who have a very slow gastrointestinal system and maybe just don't transport that pill through their GI system to the spot where it needs to go. Because it's a continuous infusion, we typically see that people can have smoothing out of their motor symptoms over the course of the day. It is a little box that you have to wear, and there's a little tube that goes into your stomach. But if you're not a good candidate for deep brain stimulation, and you're having big ups and downs throughout the day, this could be something that would be beneficial for you. So, there are a lot of different medications that we have, there are a lot of different rehabilitational options that we have, and there are also a lot of different interventions that we can do to help control the symptoms of Parkinson's disease. Sometimes it's hard because we have such limited time in clinic, and it'd be great if we had a few hours for every patient so that we could really nail down each of these. But I think that all of you that I've seen have done a really good job of taking notes and writing it down so that you can have a very directed conversation with your physician about what your bothersome symptoms are, kind of like what you want to work on at each visit. so that we can definitely think about both the motor and non-motor symptoms and what medications and different interventions we can do to help them. So that's kind of a whirlwind tour through the treatment of Parkinson's disease. I'm sure we can talk for a lot longer about that, but we will have a question session at the end. Thanks.